Hello, everybody, and welcome to another episode of Overfilled, the podcast. It's great to have you with us. And as always, the three amigos here, myself, Dr. Brooke Messer, Dr. Jamie Kuzner, we get to spend this half-hour-ish time with you today, just sharing about what overfills us, the good and the bad and the ugly of being a scleral lens fitter and a human being. And we're going to talk about a case that Brooke has today, too. She's got lots of good pictures and some videos. So hopefully we'll learn something from that together. So as we always do, we're going to start off with what overfilled us since our last episode a week ago. And Brooke, are you going to go first for us?
Sure.
Get away.
So, two quick comments. One is Hunter, my 4-year-old, had his first soccer camp. And it's on Wednesdays this month. And so he has another one tonight. And I'm pretty sure he's better than Nora on his first day. It was so cute. You know, he's like a shorter 4-year-old and had the long socks and the little shin guards. And we got some cleats at Play It Again Sports for him. And so he looked real cute and did just an awesome job. It was so fun to watch that. And I have super orange fingernails today from a bunch of scleral lens patients yesterday, which is always fun. Had 2 new fits like I do most Tuesdays. And just a good day overall of fitting patients and seeing some fits that have been, just kind of coming around, like each week getting a little bit better, or each time we see the patient. And just doing those last fine tunes. And yesterday was just a really smooth day. You don't always get that. I'm sure for those of you who fit a lot of lenses, sometimes you have good days and bad days. And yesterday was just such a smooth day. Like everything made sense. Everybody was doing great. And to have my, new resident alongside me, got a little vote of confidence that, oh yeah, I'm with somebody who actually knows what they're doing. So it was just a good week overall, both, being a human being and a scleral fitter.
Nice.
Yeah.
Jamie, you're up.
So for those of you that don't know, my family is a really big hockey fans. Okay. So my 5-year-old Olivia has been doing hockey and she's made really good strides. And so last night, this is kind of overfilled, kind of funny, she's usually like more of a timid player. Like she's not very physical. But last night, I guess there was this kid that just kept taking, the puck from everybody, as a 5-year-old would. And Olivia, I guess, accidentally just trucked this kid and took him right out, which is so out of her character. Like she didn't do it on purpose. But my husband was like, oh my gosh, she was playing so confidently. So she was having so much fun. And then she totally just trucked this kid that was kind of being a little, pain to everybody else. And it was hilarious. So it's just kind of fun. Like Brooke said, just watching your kids grow and get more confident in what they love. We got her a pair of rollerblades, and the first day that she took them out, she could just immediately do it, which I was more nervous about her on cement with rollerblades, but she loves it and she wants to keep doing it all school year. So we'll see how she does. As far as in the clinic yesterday, I did a dispense on a post LASIK patient that was really just kind of in a dark spot the last few months, where he had been to many, many doctors and had a lot of issues with depression and anxiety over his vision. He was a -10 that the surgeon had chose to do smile on him. And he just, one of those 2015 patients with a ton of glare and halos. So he had been in a few different times. And then finally, we just had the lens dispensed yesterday. And he was finally like, okay, I feel like I'm reaching an area where I'm okay with, I'm going to get some of this vision back. That I don't have poor vision the rest of my life. So it was nice to be able to dispense that lens to him and have him try it out. So I'm hopeful. So it's really down the first day that you visit people. They come to your office and then they tell you all the negativity, and it's nice to be able to dispense a lens and then they start to see, the light at the end of the tunnel. So he actually seems happy for the first time in the last 4 months. That he's been going through this journey. So I hope, when he comes in the next couple of weeks that he's still doing well with the lens. So that just made me happy, and it's all worth it when you can make somebody's life a little bit better after they've kind of been in a dark spot. So that was my overfilled.
Yeah.
Nice.
How about you, Jason?
Well, I'm going to move right on to clinic. And so I had seen this guy maybe 3-4 months ago, started seeing him. He's a veteran. He keratoconus in both eyes, pretty bad, pretty severe. Not a lot of scarring, just really steep and thin, And he had come initially for his consultation saying that, oh, by the way, going up to Chicago to the School for the Blind in 2 weeks, they're going to teach me how to use all these devices and everything because I can't see, right? And so we did a fitting on him for sclerals and got him fitted decently. But he only corrected to like 2060 and 2050 minus. And I thought, it's because his cone is so severe. But thought, with HOAs, because he doesn't have any scarring. And I told him that day while we were sitting there, I said, I think I'm going to get you to 2020 before we're done. And he's actually rides motorcycle and stuff, which he hasn't been able to do for years now. So last week he came in for a dispense of his first HOA corrected lenses. And he was about 20/25 in each eye, but over refracted to 20/20. And I told him, we're going to get you to 20/20 yet, just like I said. So he's very excited. He's a character, as you know. A lot of those 55, 60-year-old vets are. I always have lots of good stories to hear from when he comes in about his favorite barbecue places and some of his other exploits. But yeah, just a fun guy. Really, really neat to be able to do something now with lenses, as you guys are both doing HOA correcting lenses too. It's neat to be able to give people a level of vision that of course, it used to be you put a GP on them and whatever you could get them with over refraction, that was just as good as it was going to get. But to now be able to say, no, I think at some point we're going to do a lot better. Again, the cornea is clear. And so there we go. So that was really fun. And I'm pretty excited. And so maybe next time he comes in, I'll actually take a video because I'm sure he would be somebody who would be fun to play on video. I'll remember to take a video of him.
I have 2 questions. One is, are patients who have corneal scars from keratoconus a candidate for HOA correcting lenses?
Well, what do you guys think? I mean, personally, it depends on the scar and it depends on how, if it's central. So for example, we talked before the show about a patient who I just dispensed some HOA lenses to the last week, who came in for dispensing with what looked like the start of some high drops forming, pretty mild. But she was noticing her eye was a little bit sensitive and a little bit blurry, and she definitely had some edema. And so I put her HOA lens on and I tried to scan over the top of that, and it just wasn't giving me an image. I wasn't getting the reflection of the spots back into the instrument. So, you've got to be able to get the reflection back of the Shack-Hartman, targets in order to get it. I think if you can get a scan, it can help. But I don't know. I would think it's worth putting them behind the instrument and trying to get a scan. But if you're not getting data, then obviously it's not going to happen.
Yeah. So a scar below the visual axis is, something that's maybe workable versus central, because you do need that full system information coming back at you. And the second one is, I think you told me about this guy on our drive from Fargo to Grand Forks.
It's possible.
Put him for the first time. You're like, I think this is one that we're going to do HOAs on and we're going to get him there. So it's kind of that.
So it's took him a little while to get back for some of his appointments. So I'm still working on him, but we are getting there, and it's pretty cool. Yeah.
Cool. Nice. Well, with that, we can maybe roll into the case. And today it's just going to be kind of a clinical discussion, just sort of some observations that I have on this patient that I've been working on. And, she has keratoconus in general, pretty happy with her lenses, but she fogs up at about 4 to 5 hours. With fluorescein, it, takes maybe a minute or 2, and then you start to see that trickle, and then it just builds up over time. And again, in general, she's pretty darn happy, but we always try and, she might be a case where perfection is getting in the way of progress, but as we just have more and more opportunity to change more and more things about sclerals, sometimes it's hard to decide when to stop, when do we say enough is enough? And again, she definitely is looking for an improvement in her wearing experience, and we're still within warranty. So obviously I'm going to keep going and give it a shot at a few things. So I'll just show you some pictures that I took. We can just kind of talk through what we see and have some lenses on order. And, maybe next week, I ordered these lenses before the 4th of July. So I'll probably see her here soon to dispense. And then maybe in the next couple episodes, we can follow up on how she did.
Okay.
And then my second patient is just kind of an interesting OCT, talking about some ideas around how we can improve or maximize our fits on patients with significant keratoconus. So anyway, again, this is my patient who has kind of more average keratoconus, nothing super significant, definitely needs GP optics to see her best. But again, from a keratoconus perspective, maybe she's like a max K of 50 or something like that. So nothing extraordinary about the cornea. So this is her lens under white light. And when I see it, it's a little bit decentered inferior. I'm going to have to pull up her parameters quick to see if she's a quad seg or a bielevation lens, because we've been kind of tinkering with a bunch of things to try and get rid of her fogging. And we're super close. Again, if you want to go to the next slide, Jason.
Yeah. Can I just make a comment on this one?
Yep.
So this is completely off the path, but one thing that I'm noticing, and maybe it's just because I've been looking at this picture for the last minute staring at it, but look how decentered her pupil is up and nasal.
I was literally thinking that too. And I was like, gosh, is her pupil that decentered? Or maybe I just, doesn't it look
No,
like
it is. I mean, a lot of people's pupil is decentered, but hers is strikingly
more.
Decentered. Yeah. So again, that's just one of those things where you have to observe things. And so I can almost see the optic zone too, like a reflection of it. Mm-hmm. And it's down into the other way. The pupil is kind of barely, it's not barely, but it's only like 2 millimeters into the optic zone on the nasal side. So that's going to give us some visual issues too. But anyway, that was just.
And this is her side in her lenses. She's like 20/30 or something. And be interesting, if a decentered optic, she's not a multifocal, but if that was applicable.
Or HOA corrected lens. Yeah.
HOA correction. Yep. And I did talk to her about that because again, she's clear. And it's like one of those things where her keratoconus isn't that bad. And she's got a clear cornea. So you would hope that she has the opportunity to see better. We just have to get this fit finalized so that we can actually, get some reliable measurements for those HOA correcting lenses on. Anyway, so you can see where her fluorescein kind of trickles in there. And it comes in kind of straight down and then goes around. So it doesn't come in at, say, 2:00. It comes in more like at the 1:00 and then kind of follows like it does a lot of the time, right? Like it tends to come straight through that and then trickle around the shape of the cone. And that's it. Like it doesn't come in anywhere else. It looks like we can see her marks there, maybe at 4:00. So that does look like it's an echo lens, got 2 hash marks there. Mm-hmm. And so anyway, like this is how, like I'm super close and been kind of tinkering with all the APS and the elevations and things. And I need to pull up her parameters quick to see what it is, which I'll do in a second, to see if there's any, again, I only see 2 hash marks, I think. So it's probably already maybe a chamber offset from the APS versus the chamber where the bielevation or the quad sags are. But so if you go to the next one, it shows the white and the blue light next to each other. And so when I look at it, because we've done so much with trying to align the landing and the chamber, I'm sorry that I don't have one. She came in wearing this lens, so I don't have like a full fluorescein chamber image. But when I look at it, I came to the conclusion that maybe I'm a little bit tight at the 1:30-ish, 2:00, well, 1:30, I guess, at the very edge to where I'm actually creating a little bit of lift because I'm so toe down there because I've previously been trying to like seal it up, that maybe I'm allowing an adjacent area for channeling. And so I actually think that I need to flatten there. And again, I can't quite remember what I did, but interested to hear what you guys think. To just try and seal off that last little thing, because that would take care of it. And maybe we can get some comments on this lens. And then I actually tried on a different diagnostic lens at this visit just to get more information about it, try to troubleshoot a few different things. We can move into that in a second.
Mhm.
I have a question. I have a couple questions.
Mm-hmm.
So this is her worst eye, right?
This is her,
your-
yep, her worst seeing eye. I'll
Seeing
confirm
eye.
here if it's actually worse from a KC perspective.
Is she complaining about it?
The fogging.
Or-
The fogging, yes, not the vision.
Is she complaining? Okay, I was wondering because it seems like so little. But
Yeah.
I guess
So
it almost looks so good that I know this sounds so bad, but I'm like, is it really that bad?
So
And is it something where we're more like, oh, it's fogging, or is she like coming in and being like, I cannot wear it? And like, how often does she have to replace it? Like,
I think it's like 4 to 5 hours is where we're at.
Okay.
Okay.
So the picture on the left, your light source is coming from the left.
Mm-hmm.
Your picture on the right looks like the light source is coming from the right, because I can see a shadowing on the blue picture between 9 and 6. Okay.
Oh,
like I can
yeah.
see a shadow on the edge where the edge is lifting off slightly down there, where you don't pick that up from the picture on the left. The lens is decentering a little bit inferiorly, as you said. So, and the lens is also rotated like 10, 15 to the left. And so the spot where the leaking is coming in is exactly opposite the dots, right? Like if you follow the dots up to the other meridian, it's right where it's leaking. So that is probably your deepest part of your lens, is that meridian precisely. So what
it is, she's at about 4,700.
Is this by elevation?
It's a quad.
Okay.
We're at 4,700s.
Yep.
And then temporally 41 and nasally 43.
Okay.
Wow.
So my thought would be, again, and I would probably like to look at it with more fluorescein under the whole thing, but let's just, for a moment, I would probably add depth to the 4,700 meridian, take it up to like 4,800 maybe. And then I would flatten the superior APS like you talked about, but I wouldn't change the inferior.
Correct. Yep.
Because it's already lifting off a little bit.
And then let me go back to her. I have her parameters right here.
Would you flatten it like 3 steps just to kind of like just basically redistribute?
Pretty much, yeah.
So it's like 100
add
more
100
than
and
100.
pull out 90 or something like that. Yes. Yeah. I think
That's what I.
Yeah, I don't have a lot of
time
difference in the APS right now. It's mostly all chamber, and I do not have chamber offset. So
okay, and then I don't think you need it, honestly.
Yeah.
The way I look at this, again, I think I just add depth to the deeper meridian there between the dots and the leaking spot, that meridian, internally, and then I wouldn't change the inferior, but I would flatten the superior. That would be my best guess. And again, whether you take out 3 steps or just 2 out of the superior, but probably 3 if it already looks pretty tight, because the picture on the left is coming from the left, and I don't see any shadowing up there at all. Up, that whole side, the whole from 12 all the way around to 6 on the temporal side there. It looks plenty snug at the edge already.
Yeah, again, it looks good. And if she wasn't complaining, obviously it wouldn't address anything.
Yep.
If you want to go to the next slide. So just to like grab more information, I thought, I wonder what a smaller lens would look like, just because it's still decentering despite kind of, messing with these quad sags and everything. And so this is a 14.8. So just because her cornea is 11.7 or something like that, so it's just the smaller Zen diameters. And the interesting thing that I thought here was I definitely need my bielevation and everything you can see the edge lift up above. But when I was kind of pumping the lens around, and I think the next picture is a cobalt filter one, when I was kind of moving it around, it felt like the fluorescein stayed closer to the limbus than on the other lens. The other lens, because of the quad sags, doesn't have a whole lot of movement, but for what I could get, it felt like the fluorescein kind of went up to the toe and then, that kind of thing, where here you can kind of see it sort of stops like halfway between the limbus and the edge of the lens. And so I was just wondering your thoughts on, does this give us any information? I think we ended up sticking with the bigger lens, and we did kind of that like flattening of the edge and kind of just trying to seal up that very quadrantal section of the lens. We've come so far trying not to make a big rock too many boats, but just wondering if, do you ever put on different diameters when you're troubleshooting, fogging fits? And is there, typically you think bigger lenses reduce fogging because you have more landing zone to get through. But is there value in these smaller lenses on something like this? And while you mull it over, I have a quick post-op to see, and so I'll be right back. And then you can hammer me with your comments on my mediocre fitting skills.
You'll have to watch it later.
I will. I'll take notes. All right. I'll be right back.
All right.
It's funny that she brought that up because I actually just did this yesterday.
Okay.
Where I had a patient that she's in bi-elevation in a 16.0. And she just we're just still struggling. And she's like, I just feel like the lens is too big. I just feel like it's too big. I feel like I'm aware of it with my lid and whatever. So I put her in a 14.8 diagnostic, and she said it felt more comfortable.
Okay.
I felt like it looked a little. So basically what I did is, I have her baseline eaglet scans. I have her images from yesterday with the 16 and the 14. I was just going to kind of sit there and do some math and think about it. And I think I'm going to switch her to the smaller lens. And I mean, like you said, a lot of times the bigger lens feels more comfortable. I did the same thing with that post-LASIK patient I talked about yesterday. He ended up liking the 16 better. Sometimes I put one in one eye, one in the other, and the 16 fit a little bit better. But there is definitely some value with some of these smaller lenses. Usually you don't have to adjust as much.
Yeah, I mean, we know that. It's been published that the sclera at 15 millimeters or smaller is more regular. As you go beyond 15, it becomes more irregular. And so what could happen is, again, if you stay smaller, you can get by with simpler design, just adding toricity, to the chamber or to the APS. You don't have to go into quadrant specific as much, because again, the larger you go, the more you're going to run into asymmetries that make it more difficult to actually get the lens to align perfectly. So I do think there's some merit there. I think, that the other thing too to realize is that as you go from like a 16 to a 14.8, let's say, you're pulling the limbus, the limbal zone in closer and tighter to the limbus. And that's going to limit leakage as well, because you are landing closer to the limbus with your lens. And so you're going to create a situation where you are definitely going to more likely land in a more taut, regular area, and that's going to limit leakage as well. You may get leakage from a loose edge, but it may not get under the optic zone because you're limiting how much access it has to getting all the way in. But this one, again, now we can pick on Brooke because she's gone. But, the thing I noticed about this one, again, it is decentering some too. And if you look at the lens from about 12 or 1 o'clock, 12 o'clock, all the way around down to about 4 o'clock, there's dye all the way to the edge. So the edge is lifting off pretty bad. And so I don't think going smaller is a bad idea, but this one clearly needs steeper edges all the way around 360, because again, the inferior nasal area, I can see edge lift over there too. And I can see edge lift on the other side just because the dye is going all the way through to the edge. I think this one, again, either just needs a steeper APS all the way, or it needs it at least in one meridian, because I think it's too flat, and that's why it's decentering. Yet I would definitely take this lens, and if you were to go with this diameter, I would order it with a steeper edge for sure. Again, is it just one meridian or both? I think maybe actually just the 2 or the 130 down to 730 meridian definitely needs to be steepened a lot, maybe
Mhm.
by like 150 microns even, where the other meridian might actually be okay. The more I look at it, the more looking from like 1030 down to 430, actually the edge looks pretty okay.
Well, she had a lot of eye elevation in the bigger lens. It wasn't one of
Correct.
the or a lot of quad. Like one of the quads was 41, one was 47. So I feel like it's
Yes.
so hard to look at just a normal, this is a standard diagnostic, to compare the two just because this is a standard edge. Like that one had a lot of toricity in it. It had a lot of adjustments.
And I
Yeah,
wonder
I
if
mean
she
it's definitely
how much
definitely pretty
fault there
flat.
is too, because that's another way to get around fogging a little bit, is to pull the lens in as close to the cornea as you can. Obviously, reduce the sag of the lens if you can get away with it. If you've got 300 microns of vault, if you pull it back down to 200, it's going to create less foggy tears to look through, and sometimes patients may be less symptomatic just simply
Mhm.
by decreasing the sag of the lens.
I mean, I still have some patients like back before we did elevation that, we used to do Celluvisc in the bowl.
Yep.
And I have some patients that still do that and
Yep.
they still really like it and they swear by it. And that can help too. I know we can make a lot of changes with the lenses nowadays to make it a lot more aligned and all this, but there's still a place for that on some patients, or changing them to something like neutrophil or a different saline has helped. But I have some patients that have been using Celluvisc for like the past 7 years, and it
Yeah,
helps them.
I think there's value, especially when you're close. So like where she's
Yeah.
at with her fit, if we go back to this original, and if you this is all the leaking, you're getting this little bit coming in from here. And I realize that over the course of the day it gets worse.
Yeah.
But that's the place for Celluvisc. Celluvisc
Hmm.
is not going to work if the patient's getting foggy within like 30 minutes.
For sure.
You're it's a nice Band-Aid, but if the dam is broken, it's not going to, stop the water. So I think again, that is another thing where in this situation right here exactly is a perfect example of when Celluvisc might actually be helpful, because you've just got a little spot of leakage. It's otherwise pretty well lined up. And so maybe that's something we suggest to her to just think about. Again, when
Yeah.
you've got a patient where the dye is just pouring in, you've got to get the fit a lot
Right.
ideal right first.
I just always think about like, what would she have done 5 years ago before we had the quad? She would
Yeah,
have been like, wow, this is awesome. Like if you could get to that point
correct.
before.
And,
Um,
4 or 5 hours with your lens, it's like, well, for most patients, that's once a day, right? If you
yeah.
wear it 10
And a midday
hours, you could wear it
refresh.
for 5, refresh it, and then wear it for 5 more, and then you're done, right? So in a way, it's kind of like, so it's a good reminder, because you really should take it out once a day and refresh it anyway, right, patient? I mean,
Right.
sometimes it's not a bad idea to do that, and if you have an excuse to do it, like um, the patient's getting just enough fogging, so that's actually good. I want you to take it out once a day and refresh it anyway. So this helps them to do that. I don't know. It's a thought.
I think what you recommended last time is the best, where it's just basically you flatten the APS and you put more, make a lens deeper. I see that a lot too. If I put fluorescein on and the edges look pretty aligned to me, but
Mhm.
then as soon as I nudge the lens, it's like boom, flood. It's because it's just the toe is down. And I'm thinking
Yeah.
like throughout the day, they're probably looking around. They might touch their eye occasionally, and then all of a sudden a bunch of debris gets in there. And
Yep.
that, yeah, it's just because just the toe is down. So I would just do what Jason recommended to the original. I would not try
Well,
to start
Jamie
over
had a
this
great
color.
idea though, and that is, especially in a case where you're this close, is have you tried just having her add Celluvisc? Because
Oh,
that may be enough in this situation to keep it out.
It's so tiny.
we've done
So
kind of the
small.
whole gamut of fillings. We've tried different
Okay.
filling solutions,
Yep.
Clear Care, Simplus, and then a couple different buffered, unbuffered, thicker, all that kind of stuff.
Okay.
Because her first lenses she fogged quite a bit, so we added Celluvisc at the beginning,
Yeah.
and then as we've tightened everything up, I think I'm pretty sure she's still using it, but yeah,
Okay.
that
Well, that's what we were just
Celluvisc
talking about is when you've got a lot of fogging, Celluvisc really isn't that helpful, because it's not going to I believe, as I was saying, it's not going to stop the dam once it's broken. But if you just have a tiny little leak, it might work. This situation is actually when I would pull it out if you couldn't get it to resolve. I wouldn't use it if the dye was getting under much more.
A lot. Yeah.
Yeah,
Mhm.
exactly.
Do you guys go full Celluvisc or do you do a cocktail?
No.
I do a cocktail. I do it like I usually tell them like 2 or 3 drops in the bottom and then top it off with the saline.
That was my next
What do you
question.
do, Jason?
Celluvisc
Yeah,
first.
Celluvisc is too blurry. If you fill it with Celluvisc, they can't see out of it. It makes their vision foggy like it does if you just put it in your eye. So I have my patients, honestly, I have some of them using just straight eye Visia to fill because it's not as viscous. Okay, we may not get to your other case today, Brooke, because we're running up against time, but real quick, and we could talk about this another day, but maybe I'll save this for a day where we talk about managing dry eye and wetting issues with our patients. How about that?
Ivisia?
Yeah, no, just filling the lens with artificial tears, because when you fill that lens up and you have 300 microns of clearance underneath, there's a volume of tears under there, right? And then after 3 hours, your vault is down to 150. Well, what happened to all the volume of tears that was underneath that lens? It dissipated out into the tear layer of the eye, right? Well, so how about if you filled the lens with an artificial tear instead of saline, and then you're time releasing lubricant onto the ocular surface for the next 3 hours while the patient's wearing their lenses?
Like a little microdose of
like
tears.
a little microdose of tears that's constantly trickling out into their tear layer. So anybody who gets to the point, I especially do it in people who are terrible surface wetters, or those handful of patients over the years who literally will bleed from their lid wiper, their lens is so dry. Those patients, we put them on, other than punctal plugs and everything, I put them on, fill your lenses with artificial tears, but not Celluvisc. It's too thick. You've got to use, my rule of thumb is if it's a drop, if you can put a drop in your eye and it doesn't blur your vision, it's okay to fill your lens with it. If you put it in and it makes your vision blurry for a minute or two, it's too thick to fill your lens with. So
is Mibo preserved? Perfluoral
no, it is not.
It's 100% of that. It's just 100% of that ingredient. I've had people use that, and I don't know if this is another topic, but at ICSC, a lot of people were talking about using that on top of the scleral, and I was like, I thought it wasn't compatible. I didn't know if it would make it like blurry, and the company cannot tell you this, but you can. And I've been telling my scleral patients to put it on over, and it's been a game changer because I didn't know you could. I didn't know if it would make the whole lens like oily and blurry, but I've been telling my patients to use it over the lens, and it's helped a lot.
Helped a lot of my patients. Anybody who has real wetting issues, Mibo's another. Mibo's another good option. And you're right, they can't tell you that you can because it's not FDA approved, it's not indicated, but it's an off-label use, and there's no reason why it shouldn't be okay. I'm not sure I'd be keen on filling it with it, but using it over the surface, definitely. Definitely. Yeah. So a little bit spendy maybe to fill the lens with it.
Yeah, that would be
$70 a bottle or whatever. So,
yeah. Depends. Some of my patients get it for free.
Well,
1 bottle a month though.
Yeah, that's true.
Thanks again for your comments on the lenses, and I will definitely grab some photos of her dispense to see how we did. And we're going to try, and Carrie and Rivera from the Bausch lab kind of talked through her case for a bit, went over a bunch of other pictures, and maybe we can have her on for that one too, to just talk about our conversations and things, because she's always a good wealth of knowledge for talking through some of these fits that give us just need that little extra piece. So when I can't connect with you guys, Carrie's my go-to for sure. And even when I can connect with you guys, sometimes she's still my go-to. So
the more feedback, the better.
Yeah. So.
All right. Well, as always, gang, we love it when you guys send us cases. So whether it's a question about how would you deal with this kind of fit, or it's a situation where you did a fit and you're proud of it and you want to share it with the world, and we'll talk about it. Please send us your cases. They are our favorite thing to discuss on the show. You can get them sent to us. Please record a video if you can of yourself talking about the case. to overfilledthepodcast@gmail.com. Also through Instagram, you can send it to us there as well. Overfilled_the podcast on Instagram, or Overfilled the podcast on Facebook. Like, follow, whatever, all that good stuff. But ultimately, just again, send us your cases to our little places that we collect them at.
Yes.
And awesome. Thank you for that case, Brooke.
You're welcome.
And we'll get your other case next time, unless somebody else sends us something better.
All right. Yeah, we'll put it on the back burner. So,
right.
Good to see you guys again.
All right. You too. Have an awesome rest of your day.
Bye.
Bye.